So I would like to welcome you to the second annual Suarez Health Technology and Policy Speaker Series. We have a wonderful and internationally known speaker for you, but before we start, I want to tell you a bit about our school. As always, I'm sending our school to everybody, to the president of all the countries. Hope everybody can join us. So our school is a very special school of biomedical informatics. Over the past 4 to 5 years, we have tripled our size for both the student body and faculty body, which is not really accidental. It's kind of a reflection of what's happening in the industries. I think all of you have experienced, even if you do not recognize it consciously, everything you do has been fundamentally transformed by technology. So over the past 20, 30 years, the next 20, 30 years is basically a unique point in the entire human civilization, as many people would argue for that, and it's reflected by many things. I just give you some data points so to refresh your memory. So today, within 1 minute, we can generate many times of the data that was created by the year 2003. So literally, after I started to talk, we have already recreated entire human history before 2003 several times already. So that's kind of amount of data that we're generating today. And also the computing power is another indication. So all of you have smartphone. If you don't have one, let me know. Okay, well, I'm going to find the money to give you one. You cannot survive without your phone because that's the extension of your brain. So everyone has a smartphone. What doesn't matter which one you have, is 5 to 10 times faster than the biggest supercomputer in 1975 that created some series, which was used for weather forecasting rocket design. So basically, all of you have a supercomputer, or 5 or 10, not just one, in your pocket that you can use to do pretty much everything you want. And also, the cost of sequencing a human genome 15 years ago, the cost is sufficient to buy a Boeing 737. And today, you can trade your phone for your human genome. Okay, that's kind of explosion we have. And most recently, I think if you're following your speed of your cell phone download speed, okay? We are at 4G, and just a few years back is 3G. 3G, if you want to download the entire original high definition Harry Potter movie to your phone, it will take like 24 hours. With the current 4G technology, it's about 20 minutes, 10 minutes. Now we're getting to 5G, which is starting this year. Hopefully next year it will be everywhere. It may take some years. But with 5G, to download the same movie, it takes 3 seconds. Just think about the transformation it's going to bring to everything we do. Okay, so that's the kind of thing the kind of age, and I think all of us are fortunate to be part of. So that's the kind of thing we're doing in the School of Informatics, but we focus on healthcare, biomedical discovery, and all of this. So we do healthcare management through like telemedicine mobile devices to make things cheaper, more efficient. We do biomedical discoveries by linking genome and phenotypes by machine learning, artificial intelligence, and we build platform for social media, for like smoking cessation, for all of the kind of basic technologies everywhere. So that's what I was doing here. And again, our school is actually still growing, and especially of our online program, master program, is very popular and it's also very good, I have to tell you. According to some survey by the Center for Online Education, I don't know where it is located, but it's good ones for us. So we are ranked number 2 in the country for our online master program. So the first one, number 1 is Stanford, of course, yeah. But we are head of Northwestern, so I'm happy. So if you have colleagues who want to get involved, get trained in health IT, policy, informatics, artificial intelligence, machine learning, all of this, send them to our website, and we have all the information there. And you can do that. But actually, most of our students are part-time students. They have full-time jobs. We have about 15% physicians in our student body. They are learning all the excitement of technology. What we can do with all the new technology. Okay, so before I introduce our sponsor, I want to recognize two important people here, which are our University of Texas Development Board members, Joe Bridges here, and Thomas Royce. He's leading the young professionals luminary, and very interested in data, big data, all of that. So we are going to show him our school on Friday. He's going to come to our school to have a tour. I hope he will be totally convinced, if not yet. Okay. Okay, so now it's my pleasure to, first I'd thank our sponsor. It's a long name, but it's a very good name. Sponsor Suarez, Setter, Simmer, and Peace. And I want to introduce Stephen Browning, who serves as a managing partner for the Houston office of Suarez. Steve.
Thank you, Dean Zhang. Good morning. As he said, I'm Steve Browning. I'm the managing partner of the Houston office of the Voorhees Law Firm. And we are so pleased to continue our partnership with the UT Health School of Biomedical Informatics for the second annual Health Technology and Policy Speaker Series. We've enjoyed a long relationship with SBMI through our partner, Jonathan Ishii, who has served as an assistant professor and also practices in the area of healthcare, technology, and privacy. So on behalf of both Voorhees and SBMI, we thank you for joining us today, and we hope that you enjoy the program. And with that, I will turn it back over to Dean Zhang to introduce our esteemed speaker, Dr. Walter Suarez.
Okay, now is the moment you have been waiting for, right? So it's my great pleasure to introduce our distinguished speaker, Dr. Walter Suarez. Dr. Suarez earned his medical degree from the Columbia School of Medicine. I think now it's called University of Basque. And also his MPH from Tulane. And he is responsible for facilitating the development of Kaiser Permanente's internal and external health IT policy, and also providing national and international leadership and guidance on behalf of Kaiser Permanente on several health IT related domains, including digital health, EHR, health administration, privacy security, medical device, and health information exchange. So prior to joining Kaiser, Walter was the president and CEO of the Institute for HIPAA and Health IT Education and Research. In 2009, Walter was appointed by U.S. Secretary of Health and Human Services to serve in the prestigious National Committee on Vital and Health Statistics, the oldest advisory committee to HHS. Please join me to welcome Dr. Suarez.
Well, thank you so much for inviting me. It's quite an honor to be here and participate in this seminar series. As Dean Zhang mentioned, I have a background in a few areas. I am a physician by training and practice mostly as a pediatrician back in Colombia in terms of practice, and then went into public health and practice actually as a public health professional in the state of Minnesota. I worked for the Minnesota Department of Health for a few years, and then moved into health information technology, and started to work in that area about 20 years ago, starting with something that most of you probably have heard of called HIPAA. The regulation that today everybody remembers for two things, privacy and security. Not a lot of people remember that HIPAA also established some of the first national standards for electronic communication in the administrative world, all the claims and all the sort of administrative transactions that are so critical in our systems. And since then, I moved actually from Minnesota to Washington, D.C., and I have been working with Kaiser for almost 10 years in the health IT policy space. So it's a very focus space. I do look into health policy in general. And I am actually based, by virtue of location, based in Washington, D.C., rather than in California, where our headquarters are, primarily because of the policy side. And certainly there's a lot of developments, and there have been a lot of developments over the last 10 years or so on health IT. So my goal today is to take you on a little bit of a journey on health IT policy. So for those that were looking for a technical presentation, I'm probably going to disappoint you, because I'm not going to talk a lot about technical developments or technical elements. I will mention a few important things about it, and will, at the very end, delve into something that is pretty much a major trend in health technology. But I will try to cover some of the most critical elements around health information technology policy. And certainly touch on elements that, I mean, Dr. Zhang mentioned some of the things that are happening with respect to data. And he mentioned the 3 V's of the big data, right? The velocity, the speed at which we're moving data, the variety of data that we are moving, and the volume of data. And there's a lot of other V's that have been added to this concept lately, but the whole concept of big data is a major element that I will be touching on. So my topics are going to be basically cover a little bit about Kaiser Permanente and our digital health strategy, a deliberate strategy to implement many different components of a digital ecosystem. Some top new trends in health IT, and some of the things that we are seeing as critical trends in the coming days and months and years. And then focus on the health IT regulatory and legislative policy. Coming from Washington, I have to talk about policy and some of the things that are happening in the federal level, legislative and regulatory, some of the things that are happening at the state level too. And then finish up with a few words about where is e-health and health IT in the international landscape. So let's start with the context. Some ongoing realities. I think I've used this slide for more than probably 20 years. I mean, you see some of these points, and we are still challenged by many of these sort of ongoing realities of what's happening in our healthcare system. Access to coverage continues to be a challenge. The cost and the financing of our healthcare system and its sustainability, the misalignment of the payment incentives. We're just beginning to really move away from some of that misalignment. The lack of focus on health promotion, prevention, and primary care services, that continues to be a reality, a problem that we invest a lot more in areas that are not really focusing on promotion and prevention of health. The inconsistencies in quality, we continue to see overutilization, underutilization, ineffective and inefficient delivery of services, certainly patient safety issues, disparities in the healthcare system and in the healthcare sector, the fragmented, uncoordinated care, and lack of continuity of care. These are 3 critical elements that we are trying to emphasize now as really primary areas of work, trying to break the silos that exist in our system, improve the coordination of care, even as patients are being transitioned into other care. So that's a major reality today. Reduced funding for public health. Yesterday, the administration released its 2019 budget, a $3.5 trillion budget, I believe it was, in which there is significant cuts being proposed to the Department of Health and Human Services in a number of public health areas. So public health continues to be a target for defunding, and they continue to be challenged by having to do more with less. And that creates certainly this concept and this situation of a potential, and in some cases a real digital divide between what we in the clinical side have in terms of technical capabilities for collecting and analyzing data, and what public health has actually. And sometimes in many situations, you can generate an electronic message to send to public health, but public health is not necessarily ready in their systems to receive it. We're certainly pursuing an improvement in that, but now we have less funding to do so. And then certainly limited availability of the complete, reliable, real-time data at the point of care for everyone, including the care provider as well as public health. So those are some of the realities. What are some of the new challenges that we are seeing? And some of them are already here, some of them we see coming. So certainly the next generation of care delivery models. And some of these are both challenges and certainly opportunities for addressing some of these realities that I expressed. So the next generation of care delivery models are things that are beginning to take shape. Some of them have been in some work for some time now. Advanced medical homes, comprehensive primary care plus. So these are actually more of the new generation of these alternative and newer integrated care delivery models. A new payment models, certainly the concepts of moving away from payment for volume and moving into payment and really reimbursement based on value and outcomes and performance. We're beginning to see some of that, although you know, in many ways in a challenging way because of the capabilities of our systems to really measure and monitor and evaluate true population level performance of healthcare systems. The new quality-based measures that will go along with these new payment models and this next generation of care delivery models. So CMS is moving into what they call the meaningful measurement, sort of a next generation, if you will, of measures that will focus mostly on outcomes. MIPS, the merit-based incentive payment system that was implemented under MACRA, is something that is an attempt really to move us into this new approach of measuring outcomes. And certainly the National Quality Forum new Quality 2.0, sort of the next generation of quality measures. I think that's going to be another, not so much a challenge, but an opportunity. Certainly new biotechnologies and medical device developments. We're seeing everything from robotics to artificial intelligence, 3D printing, nanotechnologies, all these new developments in biotechnology and medical device. Remote monitoring and telehealth services is continuing to advance. Now more so with some of the recent developments in the budget, which I'll explain a little later. New health IT disruptors like all the medical device, mobile health apps, artificial intelligence, deep learning, blockchain, all the new technologies. These are challenging our system and helping us in many ways, or trying to help us in how to address the realities that we have. Connected devices, the entire integration of these devices into our healthcare system. The concept of patient-generated health data with expanded, granular, more complex data being collected. All the omics, the genomics, and all the areas around that. And then I wanted to put last cybersecurity, because with all the data that we're capturing and collecting and maintaining in so many different places, whether private clouds or public clouds or central repositories, cybersecurity in healthcare has become a major issue. It has been like this since probably 4 or 5 years, but it has gained intensity over the last just 2-3 years. All right, I wanted to mention also a couple of things about some of the realities that we have. Here's a picture of how Americans get healthcare coverage, and as you can see, the vast majority, almost half of the country, gets coverage through an employer-based system. We do have the public programs, Medicare and Medicaid programs, representing almost 42% of the coverage. We have individuals and uninsured, the other two groups. We still have a very significant number of uninsured in the country, regardless of several attempts, including the Affordable Care Act, to reduce that. And here's what we see as a trend over the next 3 or 4 years. We think that employers are going to continue to be steady in terms of, even though some people think they might be lowering in terms of the offering of coverage as a benefit. Certainly Medicare is going to continue to grow, given the demographics of our population. Medicaid and state children health insurance programs and other state-based programs are going to continue to grow a little bit also, to pick up some of the coverage that is going to be dropping from federal programs like the transition out, if you will, of what we know today as the Affordable Care Act. Individuals, we see it actually going down, even though some people think that they might go up in terms of employers dropping from offering this as a benefit, health as a benefit, and then letting individuals choose in the public and open market. But we feel and we fear that the uninsured will begin to pick up, and we're starting to see that already in some of the national reports. Some important market forces are also transforming what we are experiencing in healthcare. Certainly demographics and the workforce that has been changing, towards older and in some ways, multi-condition population, meaning people that have more than two or more diseases or medical conditions, which is significantly growing. And on the other end of the spectrum, the younger population, which are beginning to become a little healthier in many ways. So we have that transition in the demographics. The customer-centric focus continues to make its drive through the healthcare system. Care innovations and digitization basically is an element that is transforming really how we operate in the market. Consolidation and new players, shifting role of government. We see that now that we have a new administration, things are even shifting more so in terms of the role of government in healthcare. And the affordability pressure. How can we make offerings that are affordable in the market? Here's some of the pictures of the market dynamics, and here you see that there is some new partnerships certainly forming, a lot of mergers and acquisitions happening, and this is just in the last probably a year or so, significant consolidation, whether it is between payers or between a provider and a payer, between two providers, a lot of concentration, a lot of merger, and trying to achieve some of the economies of scale that they perceive cannot be achieved unless you grow and expand, and also trying to improve the integration of services. I think those are two of the goals I think that we see in those mergers and acquisitions. There are a lot of disruptors, from Teladoc and Theranos, although that probably was a significant disruptor that ended up having some trouble. You have Apple and the recent announcement between Apple and some 12 systems that they will have the ability to extract. Consumers that use their product will be able to extract their data out of those systems. And then you have the genetic developments, new drugs that are now offering to provide genetic therapies or are based on genetic developments. And these are significant interest. These 3 drugs were just approved by the FDA in the last 6 months and are helping advance the treatment of certain conditions using genetic technologies, genetic processes. So. And then you have also some new integrations like United and DaVita, Optum, CVS, a lot of these systems that are expanding and growing, again, major market transitions there. Another big transformation that we have seen, certainly in healthcare, has been the way we deliver care. And you can see the old approach here and the new approach, where care in the old approach was an episodic visit. Every now and then the patient would show up. Whereas now we see it more as a continuous relationship, a continuous, two-party or multi-party relationship. Management, you see it focused primarily in the clinician, and in the new approach, really a clinical team. The decision-making before happening based on training and experience, and now more evidence-based focus. The control now shifting to the patient and the patient-centeredness of the process. Variability, even though it exists still, it was left before in really clinical, based on clinical autonomy. Now it's more focused on the patient needs and the preferences, and trying to get to a personalized level of care that we haven't seen before. The information flow were restricted and now being encouraged, and in fact, in some cases, as we'll talk later, being required to happen, the flow of information through the system. So you can see several of these old approaches versus the new approaches that really are transforming how we ultimately deliver care. And taking us to this level of care, where technology allows us to enable a care anywhere and connected care. So an opportunity to really offer the patient at the center to deliver care anywhere they are, whether they are at the home or school or work or in the community, through a connected care system. And that's ultimately the goal that we at Kaiser are attempting to achieve as well. So let me transition to talk a little bit about Kaiser. Many of you have heard about Kaiser Permanente as an integrated delivery system. We're a system that integrates coverage and care delivery. So the two are intricately related through agreements that ensures that all our covered population, the 12 million members, are exclusively cared by our more than 22,000 physicians and over 50,000 nurses and medical personnel. So there is that type of a tight relationship. We do have in some regions to contract out services. We don't own hospitals in all the regions, so we contract the hospital piece in those regions, although the hospital service is delivered by one of our physicians that has hospital privileges in that facility. And we do have hospitalists that allow us to maintain that coordination. But interestingly enough, for example, in the region I live in Mid-Atlantic, we contract with hospitals. We still have to create an interface between the hospital system, in many cases a hospital system produced by Cerner, one of the vendors, an EHR vendor, and our system, which is produced by Epic. And we have to create that interface and ensure that when a patient shows up at an emergency room, there is an electronic message coming to our system saying, we have one of our members being in a hospital, and alerts the primary care provider, alerts whoever needs to be alerted, and then one of our physicians becomes responsible for that patient whenever there is a need to perform any procedures. So we do have that relationship. When the patient gets discharged, even though during the hospital event, the medical record of the patient is in the hospital system, and our provider has to enter data into that record as they are performing whatever is being performed. When the patient gets discharged, the summary of the record gets reported out electronically through electronic standards, a standard message, back to our system, and we incorporate that into our electronic system. So there is that communication, but what has been challenging really is the reality that this is not an automatic process. This is something that you have to carefully build. Now, into the future, we expect that this will be seamless, and it will happen through a flow of information through standards and through new technologies that I'll mention later. But the reality today is you have to work hard to build those type of connections and make them happen. So these are some of our statistics in terms of volumes. We do have a fairly large organization. And this is the distribution of our population in the different regions. The vast majority, of course, is in the West Coast, and particularly in California, but we do have significant presence in the East Coast and in the Colorado region. All right, some of our overall strategy focuses on these critical points. We have something we call a shared agenda, which is really a common agenda within the organization to ensure that there is a one KP, a one Kaiser Permanente. Externally, many people perceive and experience that. Internally, we have to work hard to make it happen because there's many systems, many organizations that are form Kaiser and is a complex organization. So we have to create this agenda towards making sure that everything internally works very seamlessly, just like externally is being seen and it operates. Our three goals of perform, grow, and lead, those are three corporate strategic goals. Consumer experience being another very important strategic goal and focus. Evidence-based clinical excellence, high-quality care delivery, affordability is another one of our key strategies. Balancing the growth in our lines of business and making sure that that balance that we have in terms of how many people we have in the, we have about 70% of our total enrolled population come from the employer side. So shifts in the employer side towards the individual side will affect us, and we have to balance those lines of businesses. And a strong community health engagement. And our Permanente Medicine, which is our Permanente medical groups, our physician side, they base their practice really in these four principles: evidence-based, patient-centered, performance-managed, and innovation. And I think with those elements, we pursue really the achievement of better outcomes for our population. All right, at a very high level, our digital health strategy is formed by three basic pillars. One is a connected consumer, so our members and our patients are connected to us and to them among the community that we serve. So ensuring that our patients have a very easy access to the services supported by technology. A connected care team. So our providers are offered and are supported by technology that allows them to perform and to achieve their goals in the most effective way. And then a connected workforce. We have a very large workforce that provides support from the administrative side, from the financial side, and so we need to make sure that that workforce is also supported through our technology capability. So our Kaiser Permanente Information Technology Group, which sits in between, if you will, the Kaiser Permanente Health Plan side, the Kaiser Hospital System, which is part of the health plan component, and then the provider side, the Permanente Medical Group. Those three components, the IT sits in between and provides support to all of them, along with the entire administrative structure. And here's really our investment in health IT. So health IT as a component of Kaiser's overall structure is formed by all the different tools and resources and processes and workforce and workflows that are together really working in an integrated environment to deliver this high quality, affordable care. It is a program-wide system that not just supports the clinical side through the electronic health record component, and allows for things like not just individual care, but population health management. But it supports everything else, including our administrative and consumer systems. The electronic health record system is one of those components, and we have a very, very large deployment of an electronic health record system. We call it Health Connect, and as I mentioned, is a product built on top of a Epic platform. It is the world's largest and probably one of the most advanced civilian deployment of electronic health record. We have over 30 million records on the system. We have not just one single Epic installation, we have 12 different Epic installations because each of the regions have to have its own installation, and that's part of the challenge of coordinating across all these various installations, not just because of some of the limitations really of the Epic tool. From the beginning, Epic, which was based on a programming called MUMPS, had some limitation in terms of the extent of managing records. So we have to fragment literally and install several instances of Epic. But also because of the regional nature of Kaiser, in each of the regions there is a Kaiser health plan of Colorado and Kaiser health plan of Georgia and of Mid-Atlantic. There is no company called Kaiser Permanente, believe it or not. We have 12 or we have 7 different health plan companies. And then we have equal number of Permanente medical groups in each of the states, mostly because of the way things operate in the different states. So that creates the need to integrate multiple platforms and multiple technologies, but we use only Epic as the support for the electronic health record system. And it is, going to provide us what I will mention in a few minutes, all this integrated system support. Really, the greatest benefit is having what it says up there, the right information about the right patient available to the right provider all the time, in real time. So that's the nature of the capability that we have and that we thrive to get to. In some cases, we have challenges and situations where it doesn't allow us to do that. But this is an example of the kind of situation that we had before, where every time a patient was calling our system, the responder only had about 5% of the cases full information about that person. And if the patient showed up in an ER, only 5% of the cases, the ER, clinicians would have access to the full record. And even in visits, only the 40 to 70% would have access to the entire record. Well, nowadays, a person calls our nurse line or any of the lines that we have, and they have access to the full entire record. They go to an ER, wherever that ER might be, in one of our hospital systems, and they have access to the full record. We haven't been able to ensure that if I go to one of my hospitals that I am in my region that I'm able to go to, that doctor in that point be able to access our entire record. We haven't been able to do that, and we're still working towards that goal. But in our hospitals, certainly in California, for example, we have that capability. When one of our members goes to one of our hospitals, the provider there will have full access. And then the same thing with the visits, 100%. So that is the opportunity that is offered by this technology. Now, this technology has allowed us to do what maybe other systems are not able to begin to get into because of the fact that they don't have necessarily this longitudinal view of a record, of a patient. Every time I'm in meetings with other systems, whether it's health plan systems or provider systems, they are still talking about how can we get access to the entire record when a patient is referred from one provider in one system to a provider in another system. They only see a portion, they generate their own record, and then that record doesn't necessarily go back to the other provider, and there's that disconnect, that fragmentation. And so the discussions are about the ability to create that longitudinal connection in real time. we have the opportunity to move beyond that point since we have that ability to see that. And so what are some of the technologies that are being developed to support, a next generation of capabilities? Well, I mean, certainly evidence-based care is one of the things that we have in our system. Treatment algorithms and clinical guidelines incorporated into it across the entire system. So it doesn't matter where the patient is, they will be receiving the highest quality care based on the clinical guidelines and treatment algorithm. We don't have to deal with things like eligibility when a patient comes to our system. When one of our members go to one of our clinics, or the famous and now becoming the more significant challenge, prior authorization. How do we get real-time prior authorization from payers? Well, we don't have to deal with that because there is no prior authorization in Kaiser Permanente. So there's those kind of benefits that allow us to concentrate more on the use of the technologies to support things like this ones, decision support alerts that allow us, because of the longitudinal view of a patient record, to have these alerts be exposed to any provider and every provider that sees a patient, whether they need some follow-up on a specific issues as a patient because they haven't, been under control recently or anything like that. Real-time reporting for a patient. This is a dashboard that we have, a 24/7 metric reporting that shows for each physician. This is for one physician how they're performing in diabetic patients. We have priority focus areas of conditions, diabetes, cancer, preventable conditions for the most part. So they have the view of how they are doing with the population they cover. In Kaiser, when a member enrolls, one of the first things that they do is choose their primary care provider. And the primary care provider receives a panel of patients and provides care for a panel of patients. And so that is what they see in the panel of their patients, how they're doing. We have multiple reporting capabilities. They can see individual patients, of course, and show longitudinally how they're doing. They can see a group of patients. They can see of a particular condition. They can see entire population, their entire panel on various measures about health prevention. And I'll show you, I think, one of those in a minute. So there's a lot of capabilities. And on top of it, of course, there is performance mechanisms that we show. We present to our physicians data that shows how they are doing compared to other physicians in their facility. And certainly at the beginning, that was a big challenge. I come from Minnesota, actually. Lived there in about 20 years, as I mentioned earlier. And one of the things that we used to say, you probably heard this from one of the shows there, in Minnesota, everybody's above average, right? In our providers all think that they are all above average. And what we ended up showing them is that, they are above average in some things and maybe not in other things. And they now are very actively pursuing to see these reports. Before, they didn't want to see it. Now they are very interested themselves in knowing. And there's no punitive, perception or issue about this. This is purely for them to realize areas that they have an opportunity to improve, primarily for the benefit of our members and patients. Prevention is everyone's job. That is number one thing about our system. And so whether it's a primary care or a specialist, and all the specialists, they see through the record anything that needs to be updated about a particular preventive measures. And how many, what we call care gaps, how many care gaps can we, address through these systems? Well, right now we have about 130 different care gaps built into the system. So any physician, any specialist, an ophthalmologist, and this has happened to me actually. I go to an ophthalmologist, they look at my eye and then they notice because the system alert them, they see that I haven't completed my colon cancer screening, and they give me a colon cancer screening kit. And if it's my wife, perhaps she hasn't gone to a mammography, and so they can in there schedule a mammography appointment, which if it happens to be in the same building and there is a ability to have the appointment, they can do it right there, right at the point of care. And then there is, on top of this, a lot of population health management tools. Population health for us is a major component because of certainly the size of the population that we cover and that we serve. And so we have all sorts of tools that show, in this case, for a particular provider, all the patients, and this is one tool that shows all the patients that provider has in that panel, which ones have a gap in different areas, diabetes or cancer or cardiovascular disease or anything like that. And so it presents to them, and this is done every week as they come to the work at the beginning of the week. They can see this and they can alert. And this is not just the physician, this is the care team in that clinic. So the clinic has protocols to do what we call proactive appointments and proactive pursuit of patients, meaning basically we literally try to reach patients in different ways, not just simply by sending an email, but following up with in-person visits if it's needed, or a call or any other way, to try to achieve, the whatever gap exists. There's another view of a report for, I believe this is diabetes or. Yeah, I think this primarily focuses on how we're doing with the A1C, when was the last time, what's the level of controls. So for specific conditions, we have very detailed analysis because we really want to make sure that the patient is under control. They can see, the providers can see their performance on different wellness and preventive care measures, or wellness screening diabetic patients, and they can see, through the months how they're performing with respect to controlling patients. So all these are a variety of tools that allow really, the provider to manage the care of and the provider team. This is not just a physician. The patient. We also, this is an example of a comparative analysis of a group of providers within a clinic. So these are all the private care providers here, and these are all the patients, and these are all the patients that have a overdue mammography of this group. And so it immediately brings up some analysis about the performance and the need to focus on certain areas for delivery of this type of service. And again, one of the things that this allows us to do is really be more proactive. We tend to be, and at the beginning I showed you how the old approach and the new approach, how we tend to be more, the old approach, and in some cases today some continue to be in that approach, we tend to wait until the patient shows up. We are very much, moving into the proactive pursuit of our patients to ensure that their care is maintained and improved, rather than waiting until they, are sick or not stable with a particular condition. Okay, let me cover a little bit of our consumer digital health. So, one of the critical elements is to engage the consumer more proactively also in their care, and to provide them with a lot of support about through technology tools. So we created a consumer digital strategy within the entire Kaiser Permanente digital strategy. There is a component that focuses on the consumer, and it's all about improving all the different points where the consumer might come into contact with our system. So the 5 pillars of this are this ones. When they join Kaiser Permanente, what are some of the tools that we can provide? A guided series of personalized tools that allow them to begin to interact and begin to learn about Kaiser. Accessing care anywhere, anytime is the second pillar, so allowing the patient to truly, through the technology, whether it's a portal, when they visit the portal, or their mobile device, our mobile app, I'll show it in a minute, allow consumers to set up appointments, to communicate with the doctors, to see results of labs and other things, and to receive follow-up from the docs and the clinical team, and to receive personalized education resources for their particular conditions. So it's context sensitive to that. So managing my coverage and cost is another element of support. So, how much do I have to pay for copays and things like that. We have all sorts of technology capabilities at our points of care. So we have a kiosk. We have the patient actually can use a electronic member card. We still have our regular plastic card in our system. I have my card, which interestingly enough, when you look at the number, this is another element of integration. This is my card as a member of Kaiser and as a patient. So the number that we have inside the Kaiser system is our medical record number. Is the same member number as the membership number. We are now converting this into an electronic card that the patient can access and use in their cell phone. And through using technology like RFID, the telephone can be known to be present in the clinic. And if it's coming up an appointment, the registration process can be completed even before the patient comes in front of a particular person. And the whole registration process, including if the patient has decided to pulling out whatever co-payment they have from whatever credit card or whatever payment they have chosen. So all that automation can eliminate a lot of the situations where patients have to walk into a clinic, wait until they get registered and all that. Staying healthy, so a lot of context-sensitive support in tools to allow them to maintain health and live a healthy life, and then managing their conditions. So if they have a chronic condition, they can also receive personalized health. And all this is certainly mounted in the digital infrastructure that we have, which is growing and expanding. So one of the capabilities that we have built now is a real-time video visits through not just a station type of desktop computer or some other standalone computer, but through their literally phone. So we have certainly the capability of having appointments be delivered through our mobile devices as well. These are some of the statistics of how this consumer digital technology has been helping and supporting us and our members. So we have about 70% of the eligible members online and register. We have about 275 million visits, almost 750,000 visits every day to our kp.org, which is our portal for patients. 1.1 million members acting as on behalf of a family member. So those are important elements that have to be built into the system, the ability for someone certainly to interact with the system on behalf of a family member. Our mobile kp.org, so separate from the non-mobile, I guess, portal, we have about 63% of digital visits entirely are directly from a mobile device. So a lot of activity through the mobile devices. In terms of My Health Manager, which is really the personalized health record that we have in the system, about 48 million lab test results viewed online, and you can see all sorts of statistics there, emails, online prescriptions, refills ordered, appointment schedule, over 130 million notifications sent to members, whether it was a new result, a new appointment coming, any of those kind of things. 82% of the digital visits are from members managing their care, which is an important element. Once you have a condition and need to manage the condition, we really want to make sure that the technology help them support managing that condition. So, and a lot of virtual care, 42 million telephone encounters, 34 million secure messages. We had about 16, I think it was like 10 or 12 million video visits last year. So we're expanding and moving a lot more in those kind of directions. And ultimately, the mobile device becoming so central to this, allowing the consumer to use it and interact. And interact in ways like this. This is a dermatology case where the patient takes a close-up picture, takes some context picture, so not just a close-up, but where in the area in the body this is, defines the location, it gathers non-visual symptoms and other things, and then delivers that. And through that report, dermatology is one of the areas that has expanded significantly through this technology. So really, the ability to use this technology has grown significantly within Kaiser. All right, let me switch now gears a little bit and talk about some of these new trends in health IT. So I'm going to run down through a list of what we see are sort of the newer trends and what we see are going to be the focus really of developments in 2018 through probably 2020. So the entire omics is going to continue to expand in terms of documenting, capturing, analyzing data related to genomics, proteomics, all these components. Artificial intelligence, machine learning, automation, natural language processing. Right now, as it was reported last week, I guess in a more recent report, artificial intelligence is used for primarily three things. One is search, another one is classify, and a little bit about reasoning. And we certainly expect to see search and classify be sort of more the mundane type of work that will be done, but reasoning is the next iteration and the place where a lot of growth we expect to see. Precision medicine, most of you are familiar with the national initiative from the National Institutes of Health, personalizing healthcare, including not just personalizing care when a patient has a condition like cancer that has a tumor or some sort of a component that can be decoded at the genetic level so that then there can be a development of a drug that attacks specifically that type of genetic variation of a cancer. So treating that type of cancers and other conditions like that becomes very personalized. The treatment is specifically designed for the person. And that's why one of the drugs that I mentioned that was approved by the FDA, I don't know if you heard a story about one of them, but it's the cost for delivering that drug to a patient is about $450,000. Primarily because the manufacturer, Novartis, has to actually take a sample of the genetic composition of that tumor, for example, and then develop truly a drug, a product that will specifically go and attack this particular cancer. So it's harvesting a specific type of medications to specific, not just patient, but specific types of conditions. So precision medicine, I think, is, and not only, again, in that area, that end of the spectrum, I mean, really individualized precision medicine, but also what I call precision population health and precision public health, which is now taking it at the public health level and trying to identify almost like the concept of the DNA of a community, if you will, in terms of the characteristics of that community, and then developing specific interventions and measures and programs targeted to that community based on the characteristics of that community. APIs and FHIR. How many of you have heard of FHIR? Oh, all of you. Good, excellent. Well, that is truly, as Dr. Zhang was mentioned at the beginning, this concept of data and being able to manage and access that data. Well, APIs and FHIR particularly are transforming the way we see data and we gather data and we access data. The traditional way we do is I send a query for some data and I receive a response with the data. Or I get a message coming to me without me soliciting it with some data about a patient. So it's always a document-based exchange of data where I am actually pulling out data or someone is sending me data, and so I'm going to have to collect that data. And it's a copy of the data that exists in some other place. So, I have to deal with that and then have duplicate data. FHIR and APIs are allowing the system to access the data and execute actually things at the point of source rather than extracting and pulling the data and create another copy and things like that. So some very innovative technologies that are transforming the way we deliver care. Blockchain, cyber currency, and digital ledger type of applications apply to healthcare. We're still experimenting and figuring out how this would work, particularly in areas like identity management and health information exchange. Remote monitoring and telehealth services is another one of the new big trends. It's progressing, I say there, but slowly, and expanding the telehealth services and remote monitoring. We are certainly implementing a lot of that in Kaiser as well. Cloud service transformation, so the traditional concept of a software as a service and infrastructure as a service, and all these concepts are now transforming into service as a platform, where the cloud is actually serving as a place to obtain service, not just to upload some data. So there's a cloud, sort of a next generation of cloud services that are going to change really how we manage data. Digital consumerism, we talked about quite a bit of that. There's this interesting element, patient-generated health data, how much data we're going to be handling, and again, the message about big data coming from all the different sources. Well, we got to be careful about inundating the data, overwhelming our providers and our provider systems with data, and having a way to filter and analyze, pre-analyze that data, if you will, and create appropriate alerts. Newer advances in electronic health record systems, including clinical decision support. I wanted to highlight that because that is going to be a major area of development. Internet of Health things, and then privacy, security, and cybersecurity. That will continue to be one of the biggest challenges from an organizational, technical, and business perspective. So a quick review of where we are with some of these trends. So in the omics and precision medicine side, Kaiser has implemented what we call a Kaiser Permanente research data bank. This is right now it's about 500,000 volunteer members and patients that have volunteered their data, including their genetic data. So and a lot of detailed data about their lives and their medical records history, and this is allowing us to do the kind of things that precision medicine at the national level through the National Institute of Health is trying to do as well. With respect to artificial intelligence, we're piloting projects in different areas in clinical data or in clinical care, in analytics, and also in cybersecurity. We're using artificial intelligence to manage some of the issues with respect to cybersecurity. As a system, we received about almost 5 billion attempts to access our system every day. So we had a massive operation looking at protecting our data resources. We have a cyber security control center in Denver. I shouldn't be telling you where, but but we do have it, and it is you will be amazed how, the screens, show up any and every time there's a attempt, certainly, and the sources of those attempts, which in many cases are, of course, outside of the country, but in some cases are from within the country. Artificial intelligence, population health management, I mentioned, we have an extensive portfolio of population health priorities, and we work heavily on that. Blockchain, we are considering how to apply this for identity management and for health information exchange. I think those are the two areas we're looking at blockchain capability. Cloud services, we are implementing internally our own private cloud. We haven't put much data on any public cloud outside of our systems. Digital consumerism, of course, everything that we reference is around our consumer digital strategy and adding and expanding that program. Newer advances in EHR, expanding the functionality of our KP Health Connect with advanced clinical decision support in areas such as something called appropriate use criteria. How many of you have heard of that concept? Appropriate use criteria. This is a new program that CMS is implementing to utilize electronic clinical decision support every time one order a advanced radiology imaging test. So whether it's a MRI or CT scan, if it's a Medicare patient, we have to use an electronic CDS. And this is, it's been delayed, the implementation, until 2019. There's a lot of conversations. In fact, next week we're going to be at a meeting with CMS to talk about, some of the challenges about this program and the concerns. But outside of that, we are using clinical decision support and appropriate use criteria coming from places like the American Academy of Radiology, for example, or the Nuclear Medicine Society, and places that provide appropriate use criteria for determining when and what are the kind of things that need to be fulfilled before producing or ordering a test. So Internet of Things, we're also integrating medical devices, mobile devices. That is probably one of the areas we're spending a lot of time and effort, is the mobile device integration and medical device. We are concerned, but we are also, we realize that providers are going to be bringing their own device, and patients are going to bring their own apps, bring your own app to interact with our system. And so we're building the capabilities to allow that. All right, very briefly to finish up this discussion about the regulatory outlook. So a couple of context elements. So, there's a lot of course, laws related to health IT policy. I just highlighted, the kind of high-level elements. Back in the 80s and up to 2000, the primary driver was HIPAA, the HIPAA law signed in 1996. In 2000 through 2010, really, it was dominated by the HIPAA regulations themselves that were adopted in 2003, 2004, privacy, security, electronic standards for administrative transactions. And then we had high-tech, and then we had also something called the omnibus rule that focused on breach and all of other things. We had GINA for the genetic information, and we had MMA for standards for things like e-prescribing and other things. A lot of activity then. And then from 2010 to 2018, of course, we have the Affordable Care Act that expanded. There weren't too many things on the Affordable Care Act related to health IT, but there were a few things there. But then we had the entire deployment under the High-Tech Act of the meaningful use and the EHR certification program and regulations. We also have MIPS under the MACRA regulations. We had the cybersecurity information, the Security, Information Security Act, I think it's called, CISA, major legislative initiative to have improved cybersecurity protection of what they call the 16 critical infrastructures in the country. One of them is health and public health infrastructure. And then we had 21st Century Cures from last year. So there are a lot of activities around that. That's kind of the context. What is the current political context? Well, of course, we have a new administration that is focusing on a number of things, including the repeal of the Affordable Care Act, which will carry its own major policy implications. But one of the things they're doing is regulatory relief. So we're seeing truly a shift towards deregulation in many areas, in health and health IT specifically. Redirecting existing programs. We're seeing significant shifts around that as well. There is the Health and Human Services transition, which had been challenged by some of the changes in the leadership at the leadership level. A lot of departures within the department. A lot of bringing new people. A lot of the historical culture and background being lost in many ways. Then we have the midterm elections that are shaping some of the policy and political directions. And then we have a lot of these laws that they have to deal with, including budget, disaster relief, which they just addressed through the new budget act that they adopted last week. Immigration continues to be a major topic, of course, opioid epidemic, the infrastructure initiatives of our new president, and then cybersecurity continue to dominate the debate. The most recent budget agreement, which is this bipartisan budget act of 2018, as they call it, which is a continuing resolution through March 23rd. So they still have to finalize a budget for this year that ends September of this year. But that budget, that agreement that they signed included several significant health and health IT components. And here's a quick summary of those. They eliminated the mandate on HHS to make electronic health record, the meaningful use requirements more stringent. That's the major significant element, which I'll mention in a minute, the effect. Telehealth expands the Medicare coverage for telehealth services in 3 areas, end-stage renal failure, Medicare Advantage coverage of chronic care management, and then stroke. MIPS, it includes some language to slow down the transition to MIPS, adding another 3 years to it. Expansion of existing CMMI value-based insurance model, standardization of electronic content and format of HHS programs, and then the funding of NIH. So that continues to be a major element. So that's in the budget, so some significant changes. The other big driver right now is the implementation of the 21st Century Cures Act, which included several sections related to health IT specifically. So with respect to those, I mean, you can see there's the list, the EHR usability, reducing the burden of the EHR system, conditions of certification of EHRs, the famous Trusted Exchange Framework and Common Agreement, which is currently in review, which will allow better interaction, network-to-network interaction of health information exchanges, standards adoption for interoperability, regulations around information blocking, this concept that there is a deliberate effort to block the delivery of the exchange or the exchange of health information. So regulations are coming down that defines it, what is not, and then what are the effects or impacts or penalties around it. Improve access to health information and patient-generated health data. So all these are components that are being right now implemented by CMS and others. So with respect to meaningful use, we expect to see a significant change in meaningful use in the upcoming program regulations. We expect that the upcoming IPPS, Inpatient Prospective Payment System regulation in April, will introduce a significant change in meaningful use. We've been working with CMS on that, and so there's a effect on the quality payment program, the CMS meaningful measures, HIPAA administrative standards. All these are elements that are going to be happening this year with respect to policy developments. Telehealth, as I mentioned, some important expansion of the program, although some of those don't start until 2019, but this year will be a time to begin to prepare for that change. FDA implementation, we've seen significant shift in terms of the role of some of the non-traditional regulatory agencies in health IT. I mean, FDA certainly has been very engaged, but they have a number of areas that they have to implement. One of them is this Digital Health Innovation Action Plan, which includes a proposal to how would FDA oversee and potentially regulate software, clinical software like clinical decision support and other things. But the other agencies are FCC, the Federal Communication Commission, that have a program called Connect to Health. And yesterday in the President's budget, they included a significant funding for rural broadband expansion. So we expect to see FCC pick up in that with respect to health and health IT. And then FTC, the Federal Trade Commission, here's the one agency that regulates what we call the non-HIPAA covered entities. So all the entities that now are collecting data, whether it's medical devices or mobile apps or anything else, that are outside of HIPAA, for example, Apple, are collecting a lot of, or will be able to collect and will be able to access a lot of health information without any control. They don't have any control except for what the Federal Trade Commission offers in terms of protection of consumer data, in general, consumer data, including health. But they are outside of HIPAA, so we're going to live in two different worlds. The HIPAA world that is very protected, very controlled, and we all as providers are subject to that. And then the non-HIPAA world that is all these entities that collect a lot of data and will be collecting a lot of data without any controls or major control. And then just to finish up, in NIH medicine, precision medicine will continue to expand. Cybersecurity will certainly continue to be a major topic. Implementation of the more than 140 recommendations from the Cybersecurity Task Force that was delivered, I think, June of last year. Public health IT priorities, funding the modernizing, really, of the federal and state public health grid, public health infrastructure, information infrastructure. Population health management, we expect to see advances in the accessibility of population-level data through efforts like, what 21st Century Cures Act is calling for. And then the adoption of API and FHIR. And let me just show you a couple of pictures about FHIR. This is, of course, Uber and the Uber application that we all probably use. Well, most of you might not know, and we don't need to know, and we don't want to know necessarily, that behind Uber, there's all these applications through an API that are interacting and allowing Uber to perform the service. So there is a Google map, and there is a mechanism, a platform for communication, Amazon for the infrastructure, the payment handled by another group, email. All these elements are behind the scenes, all interacting through APIs with the Uber platform. Well, conceptually, that is the idea of going to FHIR. And really, FHIR has been a brand new development. It's only less than 2 years old. And it came out of a report by a group called JSON, that called for the expansion of the use of APIs in healthcare. And now a health HL7 has, put into the development of the FHIR standards, and there is now FHIR standards for everything, whether it's interaction with the consumer data. So we as Kaiser are going to be, by January 2019, ready to receive consumer apps that a consumer has chosen to access their health data through our portal, and then we are responsible under law to deliver that data, 20 data elements. Certainly, there's all concerns, not just about the security of that app and having the app be weaponized to introduce some cybersecurity threats, but we're more concerned about the fact that we're delivering now medical data to an app, and there is this world of HIPAA that we are responsible for, but there's this world of non-HIPAA covered entities that this entity will be. So a lot of concerns around that, but certainly the spirit of allowing consumer access through an API and FHIR standards is the move. So anyway, Epic is actually Cerner. All the EHR vendors are now required to have in their system an API interface, and they are building a API app registry so we know which apps are registered with Epic to allow them to access our system. There's a lot of detail in this, but suffice to say that APIs and FHIR applies to everything: pharmacy, patient access, research, even blockchain capabilities. And so this is really expanding the capabilities that we have. Okay, so my last two slides, I promise. So very quickly, just to give you a sense of where is eHealth and health IT globally. I happen to have been a consultant for the WHO working on eHealth initiatives and developing some of the conceptual elements of national eHealth strategies. And so they have deployed a number of initiatives within WHO, and they have done a lot of assessments of where countries are. And truly, that's what the interest is. Where are the countries with respect to eHealth and health IT? So this is some statistics. 58% of the member states in WHO, which are about 198 or 192 members, are states that have a national eHealth strategy in place. So almost half of them, or a little over half. 55% have legislation that protects electronic health information, interestingly enough. And then 87% of the member states have one or more mobile health initiative, national initiative in place. This includes initiatives that use mobile devices to deliver care in rural communities, for example. Adoption of EHRs around the world continue to grow at a very relatively rapid rate. U.S. now shows a much higher adoption rates than many other countries. We have about 95% of hospitals and close to 75% of physicians, clinics with EHRs. Now, how good they are and how usable and how well they perform and whether they do all the things they promise to do, that's another question. But at least there is that installation, and there is at least a transition to the capturing electronically of data. Clinicians in health systems across the globe still struggle to locate and to access the information at the point of care, longitudinal record of patients. So we still struggle with the interoperability of those electronic health record systems. And then telehealth and telemedicine continues to grow faster in other places than in the U.S., mostly because of our current policies and limitations, state-to-state limitations. In the Americas, so in the North, Central, and South America areas, PAHO, the Pan American Health Organization, has established these 4 strategic goals for eHealth. So promote policies, public policies on eHealth. About 21 countries in the region, which includes about 40 countries, have a public policy on eHealth. Improve public health strategy through eHealth. Foster cross-country collaboration and knowledge management and digital literacy. Those are the 4 priorities. Okay, and I think this was my last slide. So I'll stop here. Thank you very much. I'll take some questions. I think we have a few minutes.
Okay, 1 minute, which is good for one important disruptive question. But afterwards, Dr. Suarez will stay here for a while, so if you have questions, you can come forward to ask more questions. Just one quick, important disruptive question. Anybody? Okay, over there.
Well, I was wondering, it's great to see all these technology and adapted into EHR system, and see like both
Well, that's an excellent question, and indeed. And our new CEO, his number one priority was affordability, and it's all about making Kaiser's offerings to the population that we serve and that we, offer our programs, making it as accessible as possible to them. So, yes, we see that through the technology, we are able to control better the cost because we reduce a lot of variability, a lot of repetitious type of tests, for example, and costs around those areas. So clearly, technology allows us to eliminate a lot of the waste, a lot of the unnecessary, services. We also see it support certainly the improvement and more effective management of care by virtue of having less complications of conditions or patients that show more or less complications. So, for example, in the asthma or diabetes, being sure that through population health tools we have a good management of the patient's health and support the patient in managing that care, we see that is going to allow us to reduce the cost. And through that reduction of cost, we're ultimately able to adjust our premium rates that we offer. So, for example, in the Affordable Care Act, the whole concept of a insurance marketplace where insurers were offering their products. In all the markets we participate and have participated, Kaiser, and we continue to participate even if the Affordable Care Act is moving away. In all of them, we have the lowest offering in terms of premium. Now, clearly, there is different levels of premium based on volumes and risks and all this. So it's important to realize that the insurance market depends on risk management, and if we offer a program that has low cost premiums but has an extensive array of services, which is what we want to offer, we have to be careful about ensure that the level of commitments that we have are not going to be, basically overwhelmed by the volume of services that are going to be offered. So, I mean, in many cases, in the offering that we provide is indeed the lowest. The services that we provide are much more comprehensive. So we are able to stay in those levels. We continue to pursue affordability. That is our goal number one. So yes, indeed, I think technology has demonstrated the ability to allow us to reduce the cost.